Mr. Chairman and dear colleagues, I wish to thank you for your having the video started. Okay, we're going to talk about the femto bulk. This morning, you have certainly heard that the big issues, the major issue with the decimate bulk is succeeding in reaching to the decimate layer. Not always we make it because it's extremely operator dependent technique. So we have tried to standardize as much as possible a very complex procedure. As you certainly know, that the problem is getting to this corneal layer. Professor San Nicola, a few years ago, has already underlined the relevance and importance of diagnosis and the difference between PT bulk and bulk. These are two procedures which are slightly different and with slightly different outcomes. But let's now focus on our issue, being how to get out, how to succeed with the cannula to exactly achieve this area with a cannula or a needle. It is to say, to reach to the pre-decimate layer. So we thought that since we had a femto laser available, it might be more likely for us to be in the right place at the right time. And so we thought that we might take this opportunity of having a femto laser available in order to create tunnels at the depth, at the distance, and with the inclination that we considered to be most adequate. So the first step is the acquisition of the thicknesses thanks to this high-resolution real-time OCT that allows us to perform pachymetry at exactly the point where we want to cut. And so it is really a real-time pachymetry, very accurate. So the corneal incision at exactly the depth that is pachymetry guided and guided by the desired shape. And then the creation of these two tunnels for our cannula. So the outcome, once the laser step is finished, we have a rim and two tunnels. I always go for two tunnels, to stay from the safe side. One actually would be enough, but I prefer to have a second one just in case. So docking, the procedure is very fast. That's the docking, alignment, centration of the treatment that with the femto laser is extremely simple and also very fast pachymetry. And then we can get started with the cut from the deepest layer going up to the surface. In a few seconds, a perfect cut is made as deep as we like. And then with the same procedure, we make the two tunnels. Here, I show you that we can move them, shift them wherever we like, back and forward, or deeper or shallower, say, and one side or the other. So it takes technically and literally 1 second. So the tunnel has just been formed. Now we will see at magnification the tunnel that has been just created. Then the donor is or should receive the same treatment, and with the femto laser, we create a full thickness treatment, of course, here. And at last, we get to the eye. So we're working on. So here we have a perfect cut, quite well centered. We have two tunnels here, probably more clearly visible at the microscope. But we only have to find the tunnel getting into, and then we are already guided at the right depth. The tunnel more or less get to this point here where I have stained, and then the the route is the how you like it, so according to the standard technique. But point is, we start from very deep inside, and so this technique brings you very easily very close to the deepest stroma layers, and this is in order to create a bubble, a bubble a decimate bubble. Then you get out, and here the technique is exactly the same. This morning I've changed and replaced my video because I have been suggested that it is extremely important to apply some viscoelastic before cutting, and since the previous video, this is an old video, so I didn't put the viscoelastic. So I've changed it this morning because I wanted to highlight how important it is to apply viscoelastic on the cornea before opening it. So the cut is widened with a spatula. This spatula was designed by Dr. Fontana, and then the remaining part of the surgery is just as usual, and then we finish it, or we trim it. This is another key step in the procedure, because the previous step brings to this step, that is to say, a really perfect lamella being created. So going back to the lamellae with the manual Trifine after having used the femto laser for some time, certainly it's really embarrassing, I might say, because it's so perfect, the cut with a laser, so you can really have it made coplanar with the recipient cut, that you will really feel like not to apply any stitches, any suture stitch. So you may see how the two structures are interfaced. So one feels like no suture should be applied, but of course instead we have to suture. This is just to show you the alignment of the edges. Quite beautiful, I would say. With the regular Trifine, yes, you can achieve it, but it's more difficult. That's the outcome one day after surgery. So the case was performed in the afternoon. This is the following morning. And you may see some bleeding from the suction, but the corneal quality of the interface is quite good. And then in the following months, the anatomic integrity has been restored almost fully. So after 9-10 months from the surgery, the visual outcome is quite good, and the stigmatism is quite low. So, and this is a typical feature of the femto laser. The edges are so well done, so perfect, that the suture is easier, and the stigmatism tend to be lower. So these are the advantages. So perfect cut in our position, less induced astigmatism, so long-term results which are good, and standardization and safety, and perforation risk, and the further reduction in recovery time, the reduction in surgical time, so from 2 hours or even 2 hours and a half, less than an hour may be enough compared to manual DALC, thanks to the creation of a lower number of bubbles. Of course, this is a more difficult technique, but consider that the surgical time is means money, means saving money and also discomfort to the patient. So it's certainly a good result. Thank you.